Hey everyone, and welcome back to the Basics. This is where we're going to unpack the science that matters step by step. So I'm Bridger Bach, and today we're going to be diving into ketamine. Now, it's an analgesic and an anesthetic that you've probably seen in action, but there's more to it than just knocking folks out or numbing pain. We're going to break it down here. Simple, straightforward, and science-packed. But before we jump in, a quick heads up. This is all about education. This isn't medical advice. I'm not here to diagnose, treat, or replace any of your providers. With that being said, let's dive in. So, ketamine exists in two stereoisomeric forms. You have S-Ketamine and R-Ketamine. They're classified as enantiomers. Enantiomers are molecules that are non-superimposable mirror images of one another. They have identical chemical compositions, but they differ in the three-dimensional configuration that makes up the molecule. The structural variance can result in distinct interactions with different receptors, yielding significant pharmacologic differences. S-ketamine demonstrates a binding affinity for the NMDA receptor, which is one of the critical mediators of pain and memory processing. That's 3 to 4 times greater than that of R-ketamine. So that enhanced affinity basically renders S-ketamine markedly more potent as an anesthetic. When it's administered intravenously, S-ketamine achieves anesthesia with greater efficacy and a more rapid resolution compared to R-ketamine. However, this increased potency is accompanied by a higher incidence of psychotomimetic effects like hallucinations, delusions, dissociative states. Experimental evidence has shown that S-ketamine induces behavioral alterations in rodents suggestive of psychotic symptoms like hyperactivity, whereas R-ketamine at equivalent doses elicits a state of relaxation in human subjects. So this disparity is attributed to S-ketamine's more robust antagonism of NMDA receptors, which intensifies these perceptual disturbances. Now, in some ways, on the other hand, R-ketamine takes a more gentle approach. It doesn't latch onto NMDA receptors as strongly, so it might have fewer of these mind-bending side effects. Patients might be more calm, less chaotic. There are some studies that indicate R-ketamine might actually be better for the treatment of depression, with stronger and longer lasting effects on brain areas like the prefrontal cortex and the hippocampus. A small human study found it quickly eased depressive symptoms with hardly any sort of dissociation or disconnected feelings. So, meanwhile, S-ketamine, which is sold as S-ketamine, is already approved for treatment-resistant depression. It's backed by clinical trials. R-ketamine is still being studied, with trials underway to test its potential. So, S-ketamine's proven, and R-ketamine is promising, and together they might explain why regular ketamine helps mood so well. Alright, now I want to go into the mechanisms of action of ketamine. And I say mechanisms because there's probably more than one way that ketamine has an effect on pain signaling. But one of the big ones is through action on the NMDA receptors. So NMDA receptors are widely expressed throughout the central nervous system. And to start this conversation, I want to look at the way the receptor itself functions. So, let's pretend that this is a pain-sensing neuron that interfaces with some sort of tissue. And you can see it going back towards the dorsal horn of the spinal cord. And if you look at this section here, where it could synapse with a secondary neuron, and you blow this up, what we're going to see are a variety of channels on the cell surface. Specifically, calcium is important here. Now let's say we have some sort of stimulus that reaches the end of this neuron. It's conducting a pain signal. Well, you have calcium channels that open on the peripheral part of this nociceptor. And calcium comes in, it binds with glutamate-containing vesicles, and it brings them to the cell surface. And this glutamate gets spilled into the neuromuscular junction. Glutamate is an excitatory neurotransmitter. So as this gets spilled out into the neuromuscular junction, it's going to go across and bind to some of the glutamate receptors on the postjunctional cell surface. There are a couple different types, but the types that I'm going to focus on are going to be called AMPA, and then also, obviously, NMDA receptors. So for AMPA receptors, these are going to be fast responding receptors. So glutamate binds and it opens up the channel. And most AMPA receptors don't let calcium through, just they're permeable to sodium and potassium. For NMDA receptors, or N-methyl D-aspartate receptors, these are permeable not only to sodium and potassium, but also calcium. I'll go over why that's important in a second. So for the AMPA receptors, glutamate binds 2 spots on each receptor, and it opens up the channel. You have sodium ions flowing from outside the neuron to inside the neuron. It allows for some potassium to escape. This starts to modify the polarity of the inside of the secondary neuron. So instead of being so negative, you start to have this positive charge build up on that cell surface. Now back to the NMDA receptor. So you have a binding site for glutamate, and you also have a binding site for glycine. Both of these are important to get the channels to become more likely to open. And I say more likely to open because even if you have these things bind, you still have a magnesium ion that functions as this like obstinate plug that blocks the receptor and prevents ions from moving in and out of the receptor. So when you have the AMPA receptors letting in this potassium, it starts to change again the internal polarity of the neuron. And that magnesium that was previously being drawn towards the inside of the cell because that negative charge starts to move away when the cell becomes more positively charged, at least the internal surface. And that then opens up the channel for things like sodium and calcium to come into the cell. And calcium isn't just quite another ion, it can be a signaling molecule of sorts as well. So inside the cell, it can actually lead to different changes. So it can turn on certain genes. It can increase the number of some receptors after a period of time. It can ultimately strengthen the connection. So it almost increases the volume of the signal that's coming in. So in pain, that's called potentiation, where a small pain starts to increase over time. And this is where ketamine can shine. It can block that NMDA channel and prevent some of these changes from occurring. Now I said that you have NMDA channels that are widely distributed throughout your central nervous system. From a pain standpoint, some of the important places include, if you look at this section of the dorsal horn, Rex lamina 1, 2, and 5. So that's where a lot of nociceptors enter into the spinal cord and synapse with secondary neurons. It's here where you can start to develop some wind-up phenomenon, where if you keep having the stimulus flooding into the spinal cord, then that can start to amplify over time. You can have development of central sensitization in this area. Another place where NMDA receptors could play a role is in the rostral ventral medulla, or RVM. So think of it like a control center. It can increase pain or decrease pain, kind of like a volume knob. So NMDA receptors here can help turn on pain facilitation. So it can send signals back to the dorsal horn to make it more reactive or more likely to signal pain. It's not wind up exactly, but it's more like a booster. So prolonged pain increases because of the loop. So ketamine could here decrease that response. So next, also there's the thalamus, and this is the brain's relay station. So pain signals ascend from the spinal cord and reach the thalamus, and especially the sensory portions of the thalamus. So NMDA receptors are all over this area, and they're responsible for passing the message on to some of the higher brain regions. So if these signals keep firing, then the thalamus also can amplify them. So it can sharpen what the body perceives. And this is another spot where ketamine can turn down this volume knob. Then there are other regions like the anterior cingulate cortex. So this area doesn't just process pain. It's important in giving an emotional weight to the pain people feel. So it's packed with NMDA receptors, and it can also strengthen pain responses over time. So it can make pain feel bigger and harder to ignore. And NMDA antagonism can help decrease the emotional response to pain. And finally, there's the cortex. So the somatosensory cortex maps out the where and how much of the pain, so it can kind of pinpoint where in the body the issue is. NMDA receptors there can ramp up the signal with repeated input. The prefrontal cortex is about control, so it shapes how we handle the pain. It's rich in NMDA receptors as well. And when pain drags on, those areas can overreact. And ketamine can step in to perhaps like reset the balance. So, from the dorsal horn to the rostroventral medulla, the thalamus, the anterior cingulate cortex, and the cortex, NMDA receptors are woven into the pain network. They can amplify, relay, color the pain. So ketamine targets these spots. It blocks the NMDA receptors that keep the pain in check, or to keep the pain in check. So I know I've gone over this point a couple times, but I just think it's an important concept. NMDA receptors are widely distributed throughout the central nervous system. So ketamine's actions on NMDA receptors can occur in multiple areas. Unlike glutamate, which is one of the keys that unlocks the channel, so to speak, ketamine doesn't compete for the same binding sites. Instead, it slips to the inside of the channel to a spot called the PCP site. But this is only really after glutamate and glycine have opened the channel. Once it's there, it can act like a stopper. So ions, especially calcium, can't really make their way internally into the cell, even if glutamate's still around. So it's a non-competitive antagonist. So ketamine works best when the channel's already active, like during intense pain or overstimulation. So that's why it's effective in tough cases. In chronic pain or hyperalgesia, when NMDA receptors are overactive and firing a lot, ketamine binds tighter because these channels are open more. It's use dependent. The busier the system, the better it blocks, or the more it blocks. So that shuts down the calcium flow, driving the wind up. That normally drives a wind up. That drives the amplification, or that drives the emotional overload in those regions we just talked about. Alright, so now I want to talk about sub-anesthetic dosing of ketamine. So that basically just means use a dose that's low enough that patients are still awake, they're still breathing on their own, but it's high enough to still have some impact on the nervous system in significant ways. So typically, we're talking about something around 0.3 to 0.5 milligrams per kilogram bolus IV. Or you could follow this with an infusion, something like 0.1 to 0.2 milligrams per kilogram per hour. At these dosing ranges, ketamine starts blocking NMDA receptors, and the same ones that play a big role in pain, memory, and mood. At subanesthetic levels, ketamine reaches concentrations in the blood of about 0.5 to maybe 1 micromolar. So that's enough to take the edge off the receptors without turning off the lights entirely. So for full anesthesia, it's somewhere around 5 to 20 micromolars. So this is definitely beneath that level. So why does that matter? Because at this range, ketamine can decrease nociception. It can help prevent hyperalgesia, the pain amplification process that we discussed before, and potentially even have mood effects. Ketamine gets broken down in the liver to norketamine, and we'll go over this a little bit more later, but that's also an active metabolite. It's not as strong, but it lasts a little bit longer. That can stick around for up to 5 hours or more, so that can prolong this effect. So to sum it up, ketamine at subanesthetic levels can provide pain benefits and mood benefits without exposing the patient to risks of general anesthesia. It's a great adjunct to all the other agents that we can use. Now, to induce anesthesia with ketamine, you typically need to give a dose anywhere from zero point 0.5 to 2 milligrams per kilogram. Usual dosing range is more like 1 to 2 milligrams per kilogram. It's got a fast onset when given IV. That's 30 to 60 seconds or so. And that can have an effect for maybe 5 to 15 minutes. If you're going to give intramuscular ketamine, so you're going to want to administer around 3 to 5 mg per kg. That takes a couple minutes to start, and it lasts closer to maybe 20 minutes or so. So there's more of a prolonged effect with that. If you push past 2 mg per kg IV, or here's where it gets interesting. So with most of our anesthetics, when we use a bispectral index or a BIS to track brainwave patterns and gauge how deep or how anesthetized someone is, typically BIS drops. Somewhere between 40 to 60 is the zone that we shoot for. But with ketamine, the BIS can stay high and it can even elevate after administration of ketamine. So the question is why does that happen? Well, with ketamine, so it preferentially binds to inhibitory interneurons in the central nervous system. And so when you remove that inhibition, you get this disorganized chatter from some of the other neurons. So you have this disorganized high energy brain activity, like gamma waves, especially in the frontal cortex. And so the BIS senses this, and it's normally built to spot the decrease in cortical activity with other drugs. So you might think oh, well, this reflects that the patient is light. They're not anesthetized. But the patient is anesthetized. It's just that the BIS doesn't really interpret the effect of ketamine all that well. So by blocking these NMDA receptors on inhibitory neurons, you cause this disorganized excitation. Alright, let's take a closer look at ketamine's role in the opioid system. So this is a lesser known perhaps, but fascinating part of its suspected effects. Now, we've talked about how ketamine blocks NMDA receptors, but it also acts with opioid receptors. That's like mu, delta, the kappa receptors. So its hold there is pretty light, meaning it doesn't bind very avidly to these receptors. It's got a binding strength called a Ki value of about 28 to 100 micromolar. Now, for comparison, morphine binds to those receptors magnitudes more strongly and in the nanomolar range. So at typical subanesthetic doses, say around 100 to 200 nanograms per milliliter in the blood, or 0.4 to 0.8 micromolar, ketamine binds only to about 1 to 3% of the opioid receptors. Now that's a small fraction, but still could make a difference. That being said, the effect that ketamine has on the opioid receptors is not likely mediated through the opioid receptor itself. And instead, it might be an allosteric modulator or perpetuate the effects of opioids within our bodies, natural opioids, and their effect on the opioid receptor. So let's look at some of the studies that have been done that led us to believe ketamine interacts with the opioid system. So in 2014, a team of researchers injected ketamine directly into the ventricular system in rats' brains, and then they measured the ability of the rats to tolerate pain using something called a tail flick test. So that's how long a rat could tolerate heat being applied to its tail before it tried to move its tail away from the heat. And it's one of the ways we have to gauge pain sensitivity or pain thresholds. So ketamine let the rats tolerate higher heat levels, meaning it raised their pain threshold. But when the researchers gave naloxone, which is an opioid antagonist, that relief disappeared. They then added something called bedside. So that stops the body's ability to break apart natural opioids, like enkephalins. So that made the ketamine's effects even stronger. And this leads us to believe that ketamine might be boosting the effect of these natural opioids. Although, bedside alone can make a difference as well, most likely. And it's not just in the brain either. So there's another study in 2019 that found ketamine could ease pain at the source. Meaning like when inflammation was triggered in a rat's paw through injection of prostaglandin E2, a low dose of ketamine applied in that area could decrease the pain. And it was found that naloxone also reversed this effect in a dose-dependent way. And it was hypothesized that the dose that they gave peripherally, around the area where the PGE2, or the prostaglandin, was injected was so low that it wouldn't have central effects. So this points to ketamine working on opioid receptors locally, outside of the central nervous system. So what about in humans? Well, there was a study done in 1999 where they set out to test this. So they gave healthy volunteers, first of all, so they inflicted a burn in healthy volunteers, and then they would give these volunteers placebo, ketamine, or ketamine with naloxone. And they're aiming to see if blocking opioid receptors would change ketamine's pain relief. So in this burn model, they are looking to cause secondary hyperalgesia. So that's amplified pain and pain sensitivity around some area of injury. And ketamine helped, but naloxone didn't antagonize the effect. So that suggests ketamine's pain relief in humans, at least in this study, didn't depend on the opioid system, unlike in rats, or wasn't even impacted by antagonizing the opioid system. In 2018, there was a study that evaluated giving patients with treatment-resistant depression a standard dose of ketamine, which is about 0.5 milligrams per kilogram IV, either with a placebo or with naltrexone, again, another opioid antagonist. So they measured improvement in something called the Hamilton Depression Rating Scale. And basically, it's a tool that scores depressive symptoms like mood and sleep, where if you have a 50% decrease, it means there was a significant benefit. So 7 out of the 12 patients saw that there was a drop in the score with ketamine plus placebo. But with naltrexone, the mood boost or the increase in mood, decrease in depressive symptoms was smaller. The disconnecting or out-of-body sensation that ketamine caused was the same in the two groups, so they still had the psychotomimetic effects or the dissociative effects. So the opioid system seems to be important for ketamine's antidepressant effects, but not necessarily for the dissociative state caused by ketamine infusions or administration. So here's the bottom line. In animals, ketamine taps into the opioid system to decrease nociception or pain signaling, and naloxone can impact that. In humans, pain relief may be less tied to the opioid system, but there's probably still room for further studies to be done. We do know that it seems like ketamine changes the response to depression, meaning that if you antagonize ketamine's effect when it's being administered to treat depression, patients don't get as much benefit. So this leads us to believe that there still is a role that ketamine has in the opioid signaling system in humans. All right, let's look at how ketamine interacts with the adrenergic and monoaminergic systems. It can have cardiovascular implications, analgesic properties, and even some mood effects. So ketamine increases circulating catecholamines by blocking norepinephrine and dopamine reuptake. It can also activate the locus coeruleus. This is a portion of the brain that's a noradrenergic signaling hub. So this results in a hyperadrenergic state. It's clinically useful for maintaining blood pressure in trauma or sepsis if you need to use ketamine as an anesthetic. And it may contribute to analgesic properties through descending spinal noradrenergic pathways. Now, as for mood, monoamines appear to support but not necessarily drive the antidepressant response. So ketamine does increase dopamine and serotonin signaling, especially in the prefrontal cortex. And preclinical studies have shown that activation contributes to the antidepressant effects, but the effects are more modulatory versus primary. Okay, so now I want to take a look at ketamine's interaction with the cholinergic system, and specifically what might be relevant for clinical practice. Now, while ketamine is best known for some of the other properties we described or some of the mechanisms, it does have a low affinity for acetylcholine receptors with a Ki value roughly somewhere in the range of 10 to 50 micromolars. The exact number isn't as important as just realizing this is weak compared to some of the other classic anticholinergics that we use in clinical medicine. That being said, it could contribute to things like sedation. Part of ketamine's hypnotic profile could come from blocking cholinergic tone or modulating it in the pons, in the brainstem arousal centers. And that could reduce some of the acetylcholine-driven wakefulness. It could also lead to things like dissociative sedation alongside the NMDA blockade that occurs. It could contribute to emergence reactions. So ketamine increases dopaminergic activity, and if you pair that with reduced cholinergic tone, you can get a neurochemical imbalance. That combo could lead to things like delirium, hallucinations, emergence reactions, especially in patients who are older or maybe pediatric patients. There can be some autonomic effects as well. Now, ketamine's, as I mentioned earlier, ketamine's anticholinergic effects are mild. And there's a bit of a nuance. With anticholinergic effects, you might expect things like dry mouth, but instead with ketamine, you often get hypersalivation and excessive secretion formation. So the question is why could that occur? Unlike glycopyrrolate, the parasympathetic tone is preserved. It doesn't shut it down. Also, there's increased sympathetic flow to the salivary gland, so that occurs because of the catecholamine surge. So clinically, we often pre-medicate with an anticholinergic like glycopyrrolate to manage secretions during sedation or induction. As for the heart rate and blood pressure effects, that's not so much anticholinergic. That's more because of the norepinephrine or the dopamine blockade that can lead to central sympathetic activation. If you're taking a test and the question mentions things like delirium, hallucinations, dissociation, or autonomic changes, don't automatically attribute that to the anticholinergic effects. I think that's an important takeaway point. Like NMDA blockade can lead to a lot of the dissociation and sedation that we see. The sympathomimetic surge can lead to things like tachycardia and hypertension. Now, the dopamine and acetylcholine imbalance can lead to some of the psychomimetic symptoms. So yes, choline does interact with the cholinergic system, but it certainly doesn't dominate it. So keep that in the back of your mind for boards and in clinical practice. So this is going to conclude part 1 of discussing ketamine as a medication, and in the next parts I want to go over some of its pharmacokinetics and then also discuss later how we use it in clinical practice and some of the data behind it to support its use, and also some of the concerns surrounding its use. So stay tuned for that. Thanks for joining us so far in Back to the Basics.